Hello everyone, my name is Taha and I'm a final year medical student, and in this video we're going to go over the management of appendicitis. So in previous videos we've had a look at the pathophysiology of appendicitis, we've had a look at the clinical presentation as well as the different investigation procedures that are available to patients presenting with appendicitis. And in today's video we're going to complete the appendicitis series by looking at the management options that are actually available to patients that present with suspected appendicitis. And the purpose of today's video isn't to just list out a bunch of facts on what the management actually is of appendicitis. We will do that just so we get a basic understanding, but the main purpose of today's video is for you to hopefully understand the reasoning as to why we pick those specific procedures and techniques for patients that present with appendicitis. So this will give you a better understanding of the actual management of appendicitis, and help you hopefully retain the information a little bit better too, so you're not just memorizing a bunch of random facts that don't form a coherent picture, right? So without further ado, we'll jump straight into the video. So we're going to bring our beloved patient back again, Mr. Whitecoat, right? Now, Mr. Whitecoat has had enough, right? We've put him through the paces, and he's finally wondering what it is, what his options are regarding management of appendicitis. Now, the very first thing that we need to actually understand with appendicitis is that if a patient presents with suspected appendicitis to the emergency department or to the GP practice, the patient will be immediately referred to the surgical team in the hospital, right? There's very little that we can actually do regarding appendicitis in the community. So the main thing that we need to understand, right, and the definitive management of appendicitis, and this is for patients who are relatively young, patients with few comorbidities, and are fairly, fit and healthy. The definitive management will be appendicectomy. Okay, now without making this too confusing, we'll have a look at the word itself. So let's just break down the word. Okay, the first part of the word is appendix, right? This obviously refers to the organ in the body that we're talking about, the appendix. And the second part of the word is ectomy. Now, this comes from the Greek word ektome, right, which just means a cutting out of something, right? So appendicectomy just simply means the surgical removal of the appendix from the body itself, right? That's just a basic understanding that we need to have. Okay, the second thing that we need to understand with an appendicectomy is that it is now standard clinical practice to perform appendicectomies via a laparoscopy. Okay, now what do I mean by a laparoscopy? Okay, so if we imagine we have a patient, okay, this is the patient lying on their bed, and this is the patient's stomach. Traditionally, what used to happen when a patient presented with appendicitis and needed to get their appendix removed, surgeons would create a scar in the body of the patient, right, in the abdominal cavity, via a scalpel. Supposed to be a scalpel there, right? And they would open up the abdominal cavity and remove the appendix through that route. This procedure is known as a laparotomy. Okay, now nowadays what actually happens is that the surgeon will actually use what we call a laparoscope, right, which is basically just a few really specialized tools, right, a camera and other laparoscopic equipment that the surgeon will actually use to remove the appendix from the body via keyhole surgery. So we actually never open up and expose the abdominal cavity, right? And the benefit of this will come to in just a minute, and that will help us with the the understanding that like I was talking about previously. So this is a laparoscopy, and excuse me, what we need to understand here is that the definitive management of appendicitis then becomes a laparoscopic appendicectomy, right? Okay. Now this is the main thing that we need to understand, and this is the majority of cases, especially in younger, fitter patients. This is the management that they will actually undergo, right? Now, the second thing that we need to understand regarding the management of appendicitis is that patients, the surgical team will often consider giving IV prophylactic antibiotics, right? Now, what does that actually mean? So in medicine, what we like to do is confuse everybody that doesn't know what the words mean, and this word here, prophylactic, all it's referring to is that we give these antibiotics preemptively, right? So preoperatively, we give the patients IV antibiotics, and this allows us, or can also be given intraoperatively, so during the operation. And this, essentially, the purpose of this is to just prevent any sort of infection before it takes place, right? So the main purpose of it is prevention, right? Because traditionally, classically, anytime that we do perform surgery, there's always a risk of infection, right? And we can never guarantee that there will be the risk will be diminished completely, but what we can do is reduce the risk of complications by quite a lot by giving these antibiotics, right? So that's the other thing that we can consider. Now, let me just get my bearings quickly. Now, so the third thing that we need to consider is if a patient presents to the surgical team and their appendix has already ruptured, right? What is it that the surgical team will actually do? So the patient will still undergo an appendicectomy, right? Because the appendix still needs to be removed, okay? But a special thing we call lavage, specifically peritoneal lavage, will take place. All this is a surgical procedure in which the surgeon will take a syringe, right? And he will draw up some saline, right? And irrigate the appendix area within the patient, and will then suck out the fluid again. And obviously with a ruptured appendix, there's a lot of fecal matter and organic matter that is spread and exposed into the peritoneal cavity, and this obviously has a lot of implications regarding the infection risk, right? Now, this can lead to peritonitis, which can then lead to sepsis as well, and in patients who may be already at risk of a high risk surgery, this can be a deadly complication that we want to avoid. So peritoneal lavage essentially is just irrigation of the appendix area. So what we do is, like I mentioned, the surgeon will draw out saline, irrigate the appendix area, and then suck up the fluid again, and then repeat that cycle until the fluid runs clear, and that allows for irrigation of the area. Why we do this over just giving standard IV antibiotics, I will again explain that in just a moment. So that explains lavage for us. The other thing that we need to consider is that, so this was the third, this is the fourth thing. The fourth thing that we need to consider is that patients who might present, to surgery that aren't actually fit for surgery itself. So patients who have multiple comorbidities, patients who are frail, elderly patients, patients who are just not able to withstand surgery itself. What will often happen, or the surgical team might decide just to opt for IV antibiotics for those patients, right? For patients unfit for surgery, okay? Now this obviously begs the question, if IV antibiotics can be given for appendicitis, then why doesn't every patient get just IV antibiotics, and we can just leave it there, right? And we can avoid surgery altogether. Again, with the reasoning for that answer, we'll go into just a moment with, we'll dive into the reasons for each of these decisions that we're actually making. One of the main issues with just giving IV antibiotics is that 20% of patients that undergo just IV antibiotics rather than, and not having had surgery performed, 20% of them will have a reoccurrence of appendicitis within the first year, right? Within 1 year's time. Okay, so now we'll go into the why. Okay, why is that we're making these decisions? Okay, so the first question that we can ask is, why do we pick surgery over just antibiotics, right? And it's a very good question, and the reasoning for this is that, the reasoning for this actually links back to the pathophysiology of appendicitis, and this is actually why it's very important that we understand the pathophysiology of appendicitis, because all of these modules link on, one after the other, on top of each other, and this is the way that we can actually build a coherent clinical picture of the disease profile itself. And by the way, guys, if you're wanting to get summarized notes of appendicitis and hundreds of other disease profiles, then have a look at the white coat textbook that I offer. I'll leave the link of the white coat textbook and a bunch of other resources in the description, so if you're interested, just click on that. Now, the reason for why we pick surgery over antibiotics is that if we draw a quick diagram of the large bowel, and we have the appendix here, right? So this is the appendix. The underlying pathophysiology and the reason why appendicitis actually formed in the first place was because there was a mechanical obstruction, right? Now, this mechanical obstruction can obviously be caused by, more oftentimes than not, is caused by a fecalith. So this is just a hardened, piece of feces that gets dislodged into the appendix, and majority of cases are actually caused by fecalith, but it can also be caused by the lymphoid tissue around the appendix becoming hyperplased, and this can also lead to the narrowing of the lumen of the appendix, and in some cases, especially in patients who are a bit elderly, the obstruction can be actually caused by a cancer. So it's something that you need to consider if a patient who is elderly presents with a new suspected appendicitis. So you need to consider things such as appendix cancer and also cecal cancer. So the cecum being obviously just the first part of the large bowel, which can compress on the appendix, can also mimic, you know, the picture of appendicitis. Okay. So that is why, so the reason for surgery is because we want to remove that mechanical obstruction, right? The antibiotics, all they're doing is fixing a step later down the pathophysiology of appendicitis. So the initial pathophysiology starts with the obstruction of the lumen. This obstruction then leads to bacterial overgrowth within the appendix. That bacterial overgrowth can lead to an increase in the lumen size, and because of built-up gases, and that can increase the pressure within the lumen, within the appendix. It can then lead to inflammation of the appendix. Can then also, because of the increased pressure, it causes venous congestion, and when there's venous congestion, it means that there is a compromise in the blood flow around this area, which can then lead to ischemia, right? Now, the antibiotics, all they are targeting is the infection, right, and subsequently the inflammation within the appendix. They're not actually fixing or reversing the mechanical obstruction, and that is exactly why we prefer surgery over antibiotics, is to actually remove the mechanical obstruction, which will then reverse the underlying pathophysiology and alleviate the symptoms of appendicitis. Okay, hopefully that makes sense to you guys. So now the second question that comes to mind is why do we pick laparoscopy over open surgery, right? And the answer to this is essentially because with laparoscopy there is not nearly as big of a scar that an incision, right, that we do compared to a laparotomy, right, an open scar. This means that this reduces the risk of the actual wound becoming, and the area becoming infected, and this can always reduce the risk of peritonitis and sepsis and other complications that are associated with this surgery. And also with it being, having less trauma on the abdominal cavity, excuse me, it also means that the return to normal bowel function is also a lot quicker, right? And the outcomes regarding the laparoscopy and open laparotomy, open surgery, they are much better as well, or if not, equal regarding their outcomes of successful surgeries. Okay. Now, the third reason, right, and this was a question that I actually had myself when researching this topic, is that why do we not just remove the obstruction? Why do we not just remove the mechanical obstruction in appendicitis rather than removing the whole appendix itself, right? And again, this links back to there's a few reasons for this. I'll just mention one or two. The main reason as to why is because the appendix is what we call a dead end organ, right? There's not actually an opening, right, for the appendix on the other side. So flushing out the appendix would be quite difficult, right? It would be near impossible, just because there's a dead end. So washing out wouldn't be an option. The other thing that we need to understand is that the pathophysiology, so when patients presents and is symptomatic of appendicitis, it usually does mean that the obstruction has taken place, the pressure in the lumen has already risen, bacterial overgrowth has taken place, it's led to the infection and inflammation, and may also has led to the infection, inflammation, and also may have led to the ischemia of the tissue surrounding the appendix and the appendix itself, right? And this is a huge issue, because even if we just remove the mechanical obstruction that's causing the appendicitis, it won't actually reverse the ischemia and the tissue death that's already taken place. And the reason why we don't want to leave ischemic tissue already in the patient is because, again, there's a huge risk of infection and reoccurrence of the appendicitis that can lead to sepsis and peritonitis or rupture later on. So there's a lot of complications involved if we do just leave the appendix within the patient after it has already undergone ischemic changes. And the final thing that we'll mention is what was the need for the lavage, right? And why can't we just get away with just using antibiotics? So again, what we need to understand is that the antibiotics, they work on the tissue and in the bloodstream, right, within the patient. What they're not doing is cleaning up the actual organic material that has spread into the abdominal cavity of the patient, right? And this is essentially why we need to do lavage, right, which is irrigation, peritoneal irrigation, because we actually need to physically remove the content that may actually cause further bacterial infection and peritonitis if there is a rupture that's taking place within the patient, right? And so that would be the management option in case the patient has had a ruptured appendix. Okay, so quite a long video, but I hope you guys have enjoyed, and I hope that's somewhat made sense to everyone. Like I mentioned, if you want summarized notes on this topic as well as hundreds of other topics across medicine and surgery, then click the link in the description below and check out the resources that I have available for you guys. If you have any questions, then you can leave them in the comments below, and I'll try my best to answer them all for you. Other than that, I hope you guys enjoy the rest of your day, and I'll see you guys next time. Take care.